Hi everyone and welcome to the Substance Abuse Skills webinar series. I'm Kate Trams and today we have invited Ed Haycraft to speak on counseling families, partners, and significant others. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist and prepare for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary to pass alcohol and drug certification exams. We recommend that if you are preparing for an exam, that you get additional preparatory help and let this course be one of many tools used to prepare. The webinar in this series is scheduled for June 17, when Matt Ignacio will present Professional Readiness, Attitudes, and Values. We will offer the American Indian and Alaska Native Behavioral Health Series, and will welcome Dr. Stephanie Craig Rushing and Amanda Gaston from the health resource organization We Are Native to discuss their programs, including the ways they use social media to promote adolescent health. For information on our webinar series, you can contact me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEHs for a $15 fee. The CEH request form is available in the download in the files pod and the webinar screen, and will also be sent in a follow-up email. Immediately following today's webinar, you'll be redirected to our GPRA evaluation. GPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us improve our programs. If you've never used the Adobe Connect system before, you may view the presentation in full screen mode by clicking on the full screen button at the top right corner of the presentation pod, which looks like 4 arrows pointing outward. To return to the regular view, click the button again. You will be muted for the duration of this webinar. Please use the Q&A pod to share your questions and comments, and we will address questions at appropriate points during the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's speaker is Ed Haycraft, and we're happy to welcome him here. He's been practicing in the field of chemical dependency since 1999 and has worked in diverse settings, including corrections, supportive programs for the homeless, adolescents, and college student programs. He's currently employed by the Department of Veterans Affairs as Regional Coordinator for the Veterans Justice Outreach Program and is adjunct faculty here at the University of Iowa School of Social Work, providing education on chemical dependency at both the undergraduate and graduate levels. He's also a member of the Motivational Interviewing Network of Trainers. So we're to have Ed here to share with us about families, partners, and significant others. Ed is just a great resource. He's been working with people from all walks of life in alcohol and drug situations, and his experience with veterans is completely valuable. So I'm happy to welcome him here. Thanks so much, Ed.
Thank you. So good afternoon, everybody. Glad to be here this afternoon at the ATTC here in Iowa City, Iowa. And I hope everyone is doing well. It's kind of a chilly, rainy day here in Iowa City, and I hope that you folks that are coming across the internet might have a little bit warmer, sunnier day. Just a few things before I kind of start into this. Because of my background in motivational interviewing, and we don't have any specific dedicated slides to MI in here, but I kind of present with that type of a background and that type of a philosophy. For those of you that have had any experience with MI, MI is just a communication style. It's a way of being with people. And the interventions that we'll talk about today can be used in addition to and along with an MI type of presentation. So I just want to take and make sure everyone's aware of that. So if you hear me maybe talk about some concepts that you have heard from motivational interviewing and things of that nature, that's why I kind of insert those things along the way. Also, along with the basic Prochaska stages of change model, which I'm sure most people are familiar with. So what our goals and objectives are today are understanding the characteristics and dynamics of families, couples, and significant others affected by substance use and substance use disorders. Be familiar with the appropriately used models of diagnosis and intervention for families, couples, and significant others. Included extended families, extended kinship, tribal family structures. Assist families, couples, and significant others to understand the interaction between family systems and substance use behaviors and disorders. Assist families, couples, and significant others to adopt strategies and behaviors that sustain recovery and maintain healthy relationships. So some of the reasons that we look at family therapy are, they know what the resources are, and they can look back about and look at the things that have worked in the family before, and also working with the veteran population, it's extremely important to use family as a resource. Many times people, however, have broken bonds with family, they've worn the family, become disconnected from the individual, not just obviously within the veteran population, but within the general population as well. When you look at people with extreme substance use disorders, mental health disorders, co-occurring disorders, you find that it can be a real strain on family relationships and family ties. So hopefully, if you can get the family involved, utilize the family as a resource, you can mitigate some of those issues and find alternative coping strategies and coping skills for the family. Some of the key concepts when looking at family therapy is that the family really it's a very gestalt type of a thought here. As far as system is more important than the sum of its parts. That the parts are interconnected, they're interrelated. There's dynamics within the family members, and that there's certain rules and certain roles that determine the function of the family within the family system, and that the systems are dynamically, carefully balancing, and there's always this change and this continuity within the family system as well. If you look specifically at families that are in crisis, many times it is a very static environment where the family is very closed off from other outside entities and is kind of protecting the status quo and very locked in many times their own type of denial, as it were, within the system in general, and very resistant to change at many times. If you look at individual therapy, obviously that's looking with the person. You identify the client, you identify the person, that's who you're working with, and it kind of helps the person obviously become more focused on themselves and their behavior. Whereas when you look at family therapy, you're looking more of the forces in your life and the things that influence the individual and have some impact on the individual. And that change is structural components of the family, not to be confused with structural family therapy, can be integrated with the family itself. Change the dynamic of the family and its vulnerability to the substance use disorder or the co-occurring disorder. So looking at some of the perspectives and therapeutic interventions that we look at here in family therapy. The Bowenian perspective, a lot of people have heard of Murray Bowman. He was born in 1913 in a small town of Waverly, Tennessee. Bowen got his BS in 1934 at the University of Tennessee in Knoxville. He received his MD in 1937 at the Medical School of the University of Tennessee in Memphis. After that, he had internships at Bellevue Hospital in New York City in 1938 and the Grasslands Hospital in Vala, New York from 1939 to 1941. Following that, he was in the military for 5 years on active duty with the Army in the United States and Europe. And during that period of time, his interest changed from going into to a medical practice or a surgery practice to psychiatry. He actually went through this process while observing the mental illness that soldiers were faced with while in combat in the combat field. And he decided that this would be something worthwhile for him to take and pursue. From 1954 to 1959, Bowen worked in the National Institute on Mental Health in Bethesda, Maryland, where he began to develop theory that would be named after him, the Bowen theory, or the Bowen family perspective. At that time, family therapy was still not as advanced as what it might be today. And he really focused his initial research on parents who lived with one adolescent schizophrenic child, which he thought could provide a dimension for all children. After this, he continued to develop his process and develop his work. And it really, after looking at theory, this kind of started to step in and take over as a therapeutic model different than specific Freudian therapy. Some of the things that we look at when talking about Bowenian perspective and Bowenian therapy, triangulation. He's really the one who kind of came up with this concept and applying it within the family therapeutic perspective. And that to put this simply for people to understand. So you've got mom, you've got dad, you've got maybe a child there, and you have this triangulation between the relationships. And if anybody's ever worked in a treatment setting or in a resident setting specifically, clients will put the clinician right in the triangle as well. So the child will go to dad and say one thing, and maybe go to mom and say the other thing, or leave out information, and there's this triangulation between the relationships. It's very interesting when you start to think about that, and that it was really, and not until the late 1950s, early 1960s, that we really saw this concept put into family therapy. And then there's the detriangulation process, which is kind of removing yourself from that. So standing back and looking at the family. Bowen kind of came up with this idea of the therapist being the coach and trying to remove themselves from that triangle in the therapeutic setting. Hence, like if you had two people in, you had a married couple in, and you're doing therapy with that couple, instead of getting involved and caught up in the middle of that, you kind of step back and really utilize yourself for the family as a resource in more of a coaching nature or coach. Henceforth came the development of I statements in therapy. Bowen has been coined as the individual who came up with the I statements in therapy to take and differentiate oneself from the triangulation process. Other concepts are differentiation of self, psychological separation of intellect and emotions, and independence of self from others, which is the opposite of fusion. So when you become fused, you become part of that process. When you differentiate, you kind of step outside of that process. And the family projection process in general. So projecting those thoughts, projecting those feelings onto other individuals within the family, as it were. The experiential perspective. This is a little bit different, and it's not used quite as much as what it has been in the past. It's gone through several different phases of popularity. It largely is founded on the idea that causes and effect of family problems is emotional suppression. So people emotionally suppressing their feelings, suppressing their thoughts, and not being open and sharing. So one of the things that you do in this type of perspective is really create a environment of openness with the family members. And as the slide says, families are treated as groups of individuals more than as just a system itself. So there's this enhanced sensitivity, more awareness of what is going on within the family unit and within the individuals themselves. So it focuses on interpersonal change and a commitment to growth, as opposed to specific problem solving. So it's not just identifying the problem, it's more of a growth process within the family. Some of the people responsible for this model are right here, Virginia Satir and Carl Whitaker. So as I had said before, it's not as popular as what it was at one time, but there are still some real strong pockets of therapeutic environments that use this type of model, and specific clinics that specialize in this type of a model. I would say that if anybody is more interested in this, that you really do some more delving into this process, because it does require an extreme amount of training to do this effectively and with precision and the way that it's really meant to be done. So it's the idea that people are resourceful, provided an environment to unlock the potential and skills that the people and that the family has within the family, like what I was talking about earlier in one of the opening slides. And that countertransference is, and this is where the whole idea of countertransference came, and that could be the emotional reactivity on the part of the therapist. So the other idea is that many times therapists, become kind of enmeshed within the family issues themselves, or the family member may say something that is either maybe as an attention-seeking type of a state, or something that might be actually very alarming, or might really get the therapist's attention. Well, the idea is to maintain just a very level head, a very calm presentation when you're exploring that, so that not counter-transferring that behavior or counter-transferring that experience into your own processes. Some of the other things that they look at are the family drawing, and family sculpting. These are some great tools that you can use when you're properly trained to do these types of things. So actually having the family sit down and drawing their thoughts of the family and how the family looks. What does the family look to them? What are some of the family myths? So family legends, family things that are passed on, maybe even from generation to generation, and identifying those within the family setting, and then family sculpting, where you actually take and have the family align themselves within the way that they feel towards the other person, and then you process that with the family, and it can be very interesting. And I remember taking a class specifically on this, and at the time learning that technique, and it's a very powerful technique when done properly. So again, this is a type of a model that is worth some possible research or some further education. The structural perspective, and this is widely used, and there's parts of this that many times people utilize within their counseling, and they don't necessarily do pure structural perspective counseling, but they use portions of it, and they take parts of it and they use it to help assess families, relationships within the family, and how the family views itself and the dynamics within the family as well. Salvador Minuchin himself was from Argentina, and was the individual, obviously, that was given the credit for this type of a model. So it not only is a unique systems, uses unique systems terminology, but also a means of depicting key family parameters and using diagrams and specific symbols within doing that. So if you kind of think about a genogram, if you ever look at the way that you structurally put together a genogram, there's a very specific way that in structural family therapy this is done. There's specific symbols and specific relationship patterns in the way that you take and identify those. It also can be used in combination with systems theory. When you're doing like a systems theory map of an individual, there's been parts of this model that have been taken out and utilized within systems theory as well. So if you look at the Minuchin, and a family is a functional or dysfunctional, or excuse me, I should say, is functional or dysfunctional based upon its ability to adapt to various stressors. The family respond. So you have the external family type of stressors, and the other things that are in the bigger system in general, which in turn rests upon the clarity and appropriateness of its subsystem boundaries. So how are the boundaries set up within the family? In healthy families, parent-children boundaries are both clear and semi-diffused, allowing the parents to interact through and with some degree of authority and negotiating between themselves, the methods and goals of parenting. From the children's side, the parents are sufficiently unmeshed from the children to allow for a degree of autonomous sibling and peer interactions to produce socialization. So if you think about the socialization that occurs within the family, Minuchin really looks at this type of a process, but not extremely rigid or so fluid as to ignore the needs of the children and the support for nurturing and guidance. Okay, so then when you look at the dysfunctional family, it exhibits a mixture of subsystems and coalitions that empower hierarchies. Like the older child is brought into the parental type of a subsystem to physically replace the emotionally absent parent. So like, let's say you have a dysfunctional parent, maybe the older child is shifted into the role of that parent, and it creates the dysfunctionality within that family, or the substance use has actually been the precipitating factor of that. So it's a little bit of a different way of looking at families. So there's an extreme emphasis on terminology. It emphasizes on quite a few different types of structures within the terminology itself. The counselor kind of joins with the family to take a leadership type of a role within doing this type of therapy. And the therapist helps kind of transform that family structure. So you map out the underlying family structure, you do the diagrams, you look at the relationships, and then you work with hopefully realigning those relationships into more of a healthy, functional type of a family structure. So again, looking at boundaries, looking at rigid and diffuse boundaries and the way that these function together. The strategic perspective is from Erik Erikson, and I've always liked looking at Erikson's models, especially development, because if you look at, if you study it, you've got Piaget, you've got Erikson, you've got Freud's stages of development, you've got Anna Freud's stages of development. I really kind of like the way that Erikson looked at this and kind of put the spin on this early on, and some of the changes that he made. Within his own ideas. He wasn't just involved as a psychologist to begin with. He actually studied in other fields, and kind of stepped into this outside of an interest and outside of an importance factor, as he felt, when he actually started studying some of the other perspectives. Batterson is another individual, or excuse me, Batson is another individual that is involved in this theory. It was actually an anthropologist, a social scientist, a visual anthropologist, and a cyberneticist, whose work kind of intersected with that of many other fields. And he had a natural ability to really look at the patterns of things that were happening, and as it says in some of the readings, patterns in the universe. And in the 1940s, he helped extend systems theory, cybernetics to the social sciences. So the things that we look at, excuse me, let me go back. Some of the concepts that we look at within this model are the paradox. So that idea that this kind statements based on valid deductions from acceptable premise. So the idea that and you hear about this in other theories in therapeutic interventions as well. There's that paradox that happens within the individual, their belief system, and what they know to be their behavior. So their behavior does not meet with their thought processes or what is deemed appropriate by society in general. So another key term within this model is the paradox injunction, where the therapist actually directs family members um, to continue their symptomatic behavior, which kind of causes this paradox within the belief system. So you kind of try to perpetuate that behavior or promote that behavior and see how the individual responds. Some of the other things that are looked at within this therapeutic model are feedback loops, metacommunication, rituals, just general systems theory, and the relationship within the family members as well. Okay, moving on now to cognitive behavioral therapy, a cognitive behavioral perspective. A lot of people are very familiar with the cognitive behavioral perspective. It's used quite widely in most therapy programs. It's a widely recognized therapeutic model, and it has a lot of research out there backing this model. It has some of the just basic concepts that we all learn in Counseling 101 when you start to look at this model, and can be used obviously as on an individual or family level, done in larger groups as well. So some of the things that you look at and the actual place of the therapist in this is seen more as a teacher or an educator within the family system. So looking at what the counselor brings into it, identifying the needs of the family, looking at maybe some of the dysfunction, maybe helping try to provide some alternate behaviors and support for those behaviors. So really looking at that the symptoms are from learned responses by the family. So, for example, this just goes back to the old styles of conditioning. Know that if dad has been drinking, and if you do this, or this, he is going to take and respond in a certain manner. So the family members are going to retreat, and they're not going to take and confront dad about his behavior, or allow for change to occur relating to the behavior, or whoever it may be in the family, whether it's dad, mom, or child that has the behavior, the target behavior that you're looking to change. So you're looking at those learned family responses to given stimuli. So what's happening in the family? What's going on? How do we respond to that in keeping things, as we're viewing it at the time, safe family? And again, many times this creates the family being closed off and not open to the change process, because people are responding in the way that they always have. They're going to the status quo. So some of the things that we look at here are also our contingency management. It's kind of where contingency management came from. So contracting, maybe providing some type of a benefit for supporting certain behavior change, operant conditioning. Sometimes looking at role rehearsal, putting the family together and actually acting out role and how the role should be, so that to give people an idea of how to respond. So actually doing role playing. How are we going to respond now to the way that this other member of our family is behaving? How are we going to respond to help perpetuate change within that behavior? Another principle is a Primic principle, which is using high probability behavior or preferred activities to reinforce low probability behavior or non-preferred activities. So some of the more current perspectives in more of the more recent research that has come recently on looking at working with families and solution-focused perspective. And I really like solution-focused therapy. This works extremely for using motivational interviewing and that type of a approach. They just mesh together very, very well. So you don't really look at an extreme, the extreme problems and the underlying pathology. So you don't take and dig into that as much. It's sometimes referred to just solution-focused therapy or brief therapy. It's obviously verbal therapy, and it's based on social constructionist philosophy. It focuses on what a client to achieve through therapy rather than the problems made them seek help. Okay, it doesn't focus on the past as much, but it focuses more on the future and what the client or the family wants and desires for change. Okay, so in the way that I always like to look at this, it's not so much where you picked up the nail in the tire, but it's more about what you're going to do to fix that hole in the tire to stop it from leaking. Okay, and in asking that question, so how would this look tomorrow if you woke up and things had changed? So and how would that look to you? What would have to happen for that to be? So really focusing on that and what it takes to get the family to the desired outcome or what it would like to see the family look at or the change to be. So and it really assumes that there are positive solutions within the family. The family knows what it needs to do to change. It's identifying those. It's very client-centered or family-centered. If you're identifying, obviously, the client as the family itself, it's very client-centered. And it looks at those solutions or those family values to be specific to the family. And as this says on the slide, no correct or valid way to live one's life. So it's really trying to remove that value system of the therapist when you're doing this type of a perspective. And it really assumes that individuals want to change, that people want to take and progress in a positive manner to get on with their life and to keep the family together and to work on the structure within the family to fix, as we sometimes think of it. And as I always say, you don't fix people, you fix cars. But to move through the problem in a process-oriented type of a manner. Okay, and again, people understand they have the skills to solve their problems, whether it's from ways that they've worked on fixing or themselves that we're not doing, that they're doing, and moving through that process. The narrative actually comes out. Michael White is the one who is most noted for this perspective. And this type of a process is again something that if you think about narrative perspective and you really want to get into it, there's a book out, Narrative Perspective by Michael White. It's a great book. It's actually a good read as well. And I recommend that if it's something that you want to look further into, that you look book and look online, because there's a lot of information online about this perspective as well. This does require some study to really understand the concepts within this type of intervention and this type of therapy. It can get kind of a little confusing at times when you start looking at this. You look at the narrative truth versus the historical truth and how those are not always the same. it's a little bit different than some of the other traditional forms of therapy and concepts that are used. Um, so there's the problem narrative stage, finding exceptions, and the recruitment of support. So kind of what you do is you have the individual actually explain their story. So the narrative story actually becomes the truth to the individual. As is simply put, if you have two people explain the same situation, you're going to have some similarities in that, and you're going to have some differences within that story and the way that people are defining that experience. In narrative therapy, you really remove the behavior from the person. So it's the behavior of the drinking, and this is also used. People have used this type of a concept. That is not new by itself, where you identify the behavior as being problematic, not the person. It's not Jimmy that is the problem. It's Jimmy's behavior. So removing that behavior and looking at that as its own individual entity, and looking at how that fits into the narrative of the story being told by both or all the different members of the family. So again, it's not the historical truth that is necessarily what is important here. Even though the truth may be that Jimmy has gotten 3 OWIs, he's gotten maybe a charge for domestic abuse or something of that nature. It's separating that and looking at the way we can take and maybe look at telling this story differently, and getting support for him within the family to help create the between the behavior and the individual. Okay, and so that's really what, as far as getting the rally of the family and the support of the family around the individual to helping the family grow and get through the process of the change process in general. So the functional family therapy, it's more what's it going to achieve, um, and it says, assumes that most family behaviors are attempts to become more or less intimate. So it's either to or away from intimacy within the relationship. So people kind of strive and kind of work to become tightly knit or less tightly knit, is what the case may be. And if you think about this, especially if you think about youth, which is kind of where this whole concept came from research on youth treatment modalities. Many times children are struggling to become more tightly enmeshed within the family unit, or sometimes fighting for freedom or separation from the family unit. It's a family-based prevention and intervention program that has been applied very successfully in quite a few different contexts, especially treating high-risk youth and their families. It's a good example of current generation of family-based treatments for adolescents and behavioral problems. So there's been a lot of research and support on this modality. And again, it's something that, especially if you're working with adolescents as your target population, is something that you'll probably want to learn more about and possibly take a class or a specific training on this modality itself. There's a lot more recent research on this modality, since it is more of a contemporary model than some of the other models that we've talked about thus today. It really looks at targeting youth and families with youth from the ages 11 to 18 from all different ethnic and cultural groups. It provides treatment to younger siblings or refer of adolescents. So if you have like younger children in the family, also if you have possibly a younger family member that has children themselves. So if you're looking at a teenage individual that's still within the family unit itself, that has had maybe a child of that nature, working with them and looking at the way that they're functioning together. It's also a short-term intervention, usually 8 to 12 sessions, and maybe up to 30 hours of direct service contact. It kind of depends on the needs of the individual. Usually these are set up over a 3-month period of time, and can continue with follow-up is again on a needed basis. All right, the family disease perspective, and I think when you look at putting anything into a disease model, it's kind of important to understand what's going on. Because if you look at the disease perspective of substance use disorders, there's a couple things that they look at. First of all, it's the progression of the use disorder as a medical condition. So I think if you stand back and you kind of process what that means, looking at it from a family perspective, the family is continuing to become more and more dysfunctional. The family deterioration can be seen as the concept of a disease model. Plus, also, it looks at the medical model itself using medication, support, and education rather than specifically exploring the network of the relationship where the problems are actually coming from. So it looks at things a little bit differently. So I think that's extremely important to understand when you look at the term family disease perspective or look at a substance use disorder from the disease or progressive disease type of a model. Some of the other concepts that are important to be aware of are the multi-systemic and multi-dimensional perspectives. So you kind of combine these different therapeutic interventions that we're talking about. I always say, and this is just me, I always say everything you're doing requires a little bit of cognitive intervention. I mean, you're changing the way that people perceive given stimulus. You're looking at the way that they're interacting with each other and trying to redefine that. So there's some type of a cognitive change, no matter what type of a therapeutic intervention you're using. To shift the way that you're presenting, just to keep the adolescent engaged in treatment. And I would say that with anybody as well. It's just a very it's a very good thing as a clinician to have many different tools in your tool belt, as it were. Hence, I was talking about MI earlier. MI is a great communication style and therapeutic tool to use. However, it doesn't fit all situations. And you also need to be able to understand when to step out of that and actually put the intervention in place. So not using it solely as the sole type of communication modality with the individual. So using that combination of techniques, and it's very important, especially if you set for an exam, to know that you're going to have to be aware of more than just one therapeutic type of intervention. Because if you look at 12-step programming, it's way different than cognitive behavioral, which is different than structural family therapy. So it's being aware of those and being able to at least, especially as a young clinician, have some awareness of those. And then as you progress, becoming more educated on the styles that you really see the need for in your own clinical setting and clinical environment. So kind of switching gears a little bit, we're going to look at some cultural considerations. And I'm going to say that this is so important in counseling to be aware of. because many times when you're counseling and you're working with groups of people, you sometimes take this for granted. And if you're wrapped up and you're busy and you're going through your day and you have somebody from a special population walk in your door, um, and you don't have some at least awareness to that, it can be very problematic, and it can really reduce your effectiveness with that individual or that client or the family that you're working with. And this is true with the VA system as well, because the VA has a very strong representation on minorities, the Native American community, uh, uh, Hispanic population, the American community, the LGBT community. Um, you see all these extremely represented within the VA population. So not only when you're with a veteran, do you have to be knowledgeable of the issues that a veteran faces, but you need to be also aware of the cultural considerations where that individual has come from and where the family is embedded. So some of the definitions, obviously the family of origin, the birth or biological system, or any family system instrumental or significant in a client's early development or enculturation process. Um, so obviously we have more of a global view of this today than what we might have even 50 years ago, 35 years ago. And to look at this, you really have to understand, and I always use the term cultural competency here, being culturally competent. And there's always this question of what in the heck is cultural competency? And I think this one statement right here, is our own worldview healthy? I think also identifying, and I talk about this as well when I teach sociology. We have these determined notions. When you start looking at prejudice and discrimination, where does that come from? Well, it comes from what we've learned as we've been enculturated into society, and we've come from ourselves. And the fact that from just the way that cognition works, we have predetermined notions about different types of people. You have somebody walking down the street, you see them, and you automatically, you attend to that, and it goes in, it's processed in the brain, and you have an automatic response to that, okay? And knowing that there are probably some inconsistent thoughts that you might have about certain groups of people. Okay, and to me, that's what cultural competency is: knowing that we probably all have those, knowing that we all have what does the quintessential gay person look like to us, and the manners and behaviorisms that go along with that. That we probably have those, and we respond to those. All right, so that awareness, to me, that's cultural competency. At the same time, the other thing that is so important on this slide is overemphasizing that or overreacting. You got to be really careful with that, because sometimes people will kind of catch you off guard. You'll overreact or you'll overrespond, and that can really have a detrimental effect in the relationship between the counselor or the therapist and the client. Okay, because when it really comes down to it, everybody, kind of has the same, innate goals, as far as health, caring about their families, caring about their family units. There's just the other things that are surrounding those families that might have a lot to do with the change process and where their own value systems have come from. So it's just something that I think is very important for people to be aware of. So we're looking at these different groups here. They're going to be the ones that we're talking about right here today. And again, this is a real brief coverage of this. Obviously, there's much more in-depth trainings and classes on this issue, and I highly recommend people look into that, especially if you feel there are certain deficits in your knowledge base. So with African American families, you're going to find a little bit of a different component, obviously, than if you're looking at people with a Middle or Southern European type of a background. Um, and obviously, this is not all African American families, but when you look at an African American family, you look at the statistics out there, you're more likely to see single African American mothers than within any other population. Okay, there's going to be lots of issues within that, especially if you have a male present. That can sometimes have a negative impact on the family unit. And if you look at other things that are structural within society in general, it can really affect this. Some of the other things within the African American family are the use of kinships that are in place. You're going to see many times within the African American family, you're going to see a hierarchy of family different than what you might be used to yourself. So relying on the family kinships, relying on like an aunt or a grandparent, not uncommon. Many times, actually, you'll see the grandparent, the mother, and then the child all living together. So the family structure might look a little bit different than what you're used to. And so the way that you're going to take and apply your intervention is probably going to be a little bit different as well. Hispanic and Latino families, very traditionally close-knit groups, okay? And also many times not open to the uh, uh, outside intervention from another person. Okay, so also the term familial goes beyond the nuclear family. This can be a generational thing. Many times, and not uncommon, will you see several generations living together, and with the extended family being a very important part of the family unit itself. Certain individuals within the family have, as it says, a moral responsibility to aid other members of the family, and it kind of depends on the family value system. This may be sometimes a son or a daughter, depending on the cultural belief system of the family, and actually the where the family is originated from. Where is this Hispanic family? Where are their roots? And so what is their value system that's related to the roots of that family? There's a tremendous amount of enculturation within the family, a great deal of desire many times to keep and preserve family values and family tradition within the family. And there's the extended family within the community itself is many times very, very strong. Which brings me to looking at the Native American families. Because we're very closely related to the Fox and Sioux tribes here in Sac and Fox tribes here in Iowa. We have I have worked with several Native American veterans, and it can be very challenging working with the Native American population, depending also on how are into their own culture and their own background and within the tribe itself, whether they want to receive treatment from somebody in the tribe, whether they don't want to receive any treatment from someone in the tribe. In the case of the last person I went with, he didn't want the tribe knowing at all what was going on with his substance use disorder and wanted it kept completely separate. Very much a hierarchical structure within many of these families. The system itself is different than what we might perceive, and the tribal communities can be very blocked off from outsiders coming in. If you've got somebody, like let's say you've got somebody that gets picked up for an OWI and you're wanting to provide counseling, or you're maybe the agency that provides counseling for that area, and the person gets referred in to see you, you may have to communicate with other members of that tribe to be able to do that. There may be like an elder in the tribe or somebody that they consider to be a person of wisdom that you need to respond to get that, and their value system is going to be significantly different than what you might be used to working in just your regular clinical setting. Also understanding the family system within the tribe itself is very important. And the best way that I can describe that from what I have learned with this population is, like, let's say you've got a third cousin or a cousin, twice removed, and you've got their spouse. Okay, that probably doesn't mean a whole lot to you, coming from a Caucasian background, if that's what you happen to be, or maybe from some of the other backgrounds that we've talked about. You put that same person as that relationship within the Native American tribe, it may be a very strong relationship. That person might have as much influence in that family is what a brother or sister might happen to have. So looking at the hierarchy, the structure within the family, the tribal values and mores is very, very important when working within this community. If you look at the 7 values of the Dakota, Lakota, and Dakota life, this is a very holistic type of a philosophy. So you're looking at prayer, wisdom, honesty and truth, respect, caring and compassion, generosity and helping, and humility. And I think respect and humility right there, if you look at those, if you don't take anything else off of this slide, other than the respect and the humility, you really need to be aware of those things working with individuals from this type of a cultural ethnic background. And I would say probably working with anybody in general. And understanding that their concepts of time might be different than ours, things of that nature. And you, for example, myself, I'm kind of type A. So if you start working with somebody with this type of a background, and you go in with your type A, just self-driven type of a presentation, probably going to shut people off pretty darn quick. LGBT folks have replaced family networks. Okay, so maybe their families aren't supportive of their lifestyle and what they've gone on to do. So it's important to understand that the parameters around what you look at may be broader kinships and relationships than what you are accustomed to. Um, I think the bottom one here too, looking at some of the issues that have affected the LGBT community are very important. And also, if you look at the rates of substance use within the LGBT community, they are quite high. And there's several different thoughts around that, why that might be. And I think even if you just want to pull out the members in our community. So stages of change. And we'll back to these issues with the LGBT community in just a few minutes. Um, so when you look at the family and change, it's much like looking at just the individual. So attaining sobriety, adjusting sobriety, and then term sobriety and the maintenance. So, recognizing the problem, looking at the issue, what are we going to do, adjusting to, attaining the sobriety itself, and then adjusting to it, and then the continuing maintenance. Some of the family dynamics are codependency. When I look at this, the codependency really to me is because what is codependency? It's the dependence of the individual on the person with the substance use disorder. So you're actually kind of acting in a dependent fashion towards that individual. So these are just some of the concepts that we look at within the family dynamic itself. Sometimes, especially within dysfunctional families, you'll find overreacting, hypervigilance, low tolerance for stress. That's not just the person with the substance use disorder itself, it's within the family itself, because the family is a codependent entity, really is ill itself. The family is ill. And I just, you sit around and you talk about this collectively within clinical staffing. The family structure itself, dysfunctional is one way of looking at it, ill is another way of looking at it. If you think about it that way, sometimes it helps you wrap your brain around it. Sometimes people feel like they don't have the ability to take and change family structure, or there's powerlessness within the family, and many times it results in domestic violence. The domestic violence statistics are very poorly kept because when I present this in sociology, they say anywhere from 35 to 78% of domestic violence is happening within substance use in the house, and I'm a higher number. I think a lot of domestic violence is occurring when people are intoxicated or under the influence of substances. When the child lives with a partner and a minor child, that many times children become maltreated. Okay, so you have this maltreatment of the child. And they show that the maltreatment is actually more destructive to the child than actual physical abuse itself. Children many times feel extremely guilty. They become withdrawn. They have problems trusting with intimacy, and it can really stagnate the emotional growth of the child. It's very important to look at that with if you're working with the family as a total unit. Increase for mood and anxiety disorders, acting out, other things that happen within the family, obviously separation, violence within the relationship. This may be where the child itself is exposed to violence. And some children actually, and this is also in the research as well, do become very resilient and adapt to this. So it's kind of hard to tell what's going to happen down the road with the child. If you look at the adolescent that lives with the family of origin, obviously, many times you have delinquency occurring. You might have developmental disorders, developmental impairment, impulsivity. And when you look at what's going on from a neurological standpoint, the brain doesn't usually develop in young women, sometime 18-ish, young men, not maybe until 23, 24, 25. Okay, it's a process called the myelinization process. So people are really way more likely to do impulsive things at a younger age, and that's because of that. When you add substances to it, they're saying in the more recent research that it stunts that final development stage of the individual. It's one of the reasons that the drinking ages nationally have been really put at the age of 21, so that younger adolescents are hopefully not going to be drinking as much as maybe in past generations where the drinking age was lower. Research is still out on some of that. But the impulsivity is greatly influenced by that, which leads to some of these other things, the risky sexual behavior, the delinquency, the violent behavior, things of that nature. Effects of substance use in family structures. So it kind of depends again. If the client lives with the partner with minor children, the client is part of a blended family. And I've also had lots of problems with clients with blended families, because if you're working with an adolescent that's part of a blended family, you may be getting competing value systems from the actual biological parent, as opposed to the parent that has maybe married in, or maybe the other siblings that have been brought into the relationship. Okay? So counselor involvement. Looking at different levels of actual involvement with the individual. So you might be minimally involved. You might just take and not have a lot of involvement with the family. Like, let's say you're working with somebody as an identified patient, and the actual involvement with the family might not be that embedded. You may provide more advice or coaching. You may be more involved with feelings and support, or you might actually be doing a full-out intervention or a brief focused intervention. The 7 C's, and these are really interesting to look at. So to walk through these quickly with you, we have the character features. So what does I look at this, again, I'm going to steal from sociology, the master status of the person. So how did the person identify themselves? What important characteristics are important to them? The culture and ethic factors, which we kind of just talked about a little bit. How have those been put in place to support and develop the individual and culturate the individual? Contract features. So how does, in the relationship, how do they relate with each other? How do they make decisions? How do they make exceptions with each? Okay, so an effective contract, you got to be able to define it, It must be attainable, mutually agreed upon, and beneficial to both parties or both partners within the relationship. Are individuals committed to the relationship? Are you committed? Are you going to be committed to this change process? Are you going to committed to being loyal to each other and to what it's going to take to get through the process? Is there caring? How does the caring present itself within the family? Is it emotional and physical intimacy? How do the individuals within the family relate to each other? Even if you're looking at siblings and parents and whatever the case may be, they show affection to each other, support and empathy within the family unit. How do individuals communicate? Is it positive communication? Is it negative communication? How do people communicate? Very important. It's also one of the things that you may be actually addressing within the counseling session itself, especially if you're doing an intervention. How does this communication take place? How can it go from being unhealthy, negative communication to being positive communication? And then conflict resolution. And this is just like any type of an intervention that you're going to use. And you can look at and it applies to many different things. But I love this SOLVE acronym here. Slow down, look at the problem, identify the problem. What are the options we have? Okay, so maybe some contracting might be coming into place here. Get the consequences of the options that we can present. So what are going to be the latent and manifest functions? So what is the intended function of the change going to look like? And maybe some unintended things that may happen as the result of the change or the options that we're discussing here, and then vote on it. And then after we've put this in place, evaluate it. So it very much looks like implementation type of a model, and it should be. And it should be beneficial to the members of the family, equitably. So kind of the summary, the personal value systems of the family, how do they view themselves? What's the affectional structure look like? Are they loyal? How's their communication look like? What are the traditions and the cultural and ethical backgrounds of the family? What type of a contract is in place? How do they view contracts? Even if they're not, you don't just say, I'm having a contract with my spouse, but people do. Okay, so that's how that communication process works. And how are they solving those problems? What's the anger management look like? And maybe somebody does need to be referred to anger management. That's not all out of the question as well. So some of the current perspectives on the LGBT community. Again, as I said, high rates of substance use and other issues within the LGBT community, many times because of the cultural stressors put in place by society on people that don't feel comfortable within their own skin because of the external stimulus and cues that they're getting from society. So it was actually seen as a mental health disorder at one point, and it came out when they changed the DSM 1973. They took it out as a mental health disorder. Looking at some of the terminology, it continues to expand the way that we actually look at this and the way that we treat people. So lesbian, gay, bisexual, transgendered, questioning, queer, intersex, two-spirit, and allies. Two-spirit is from the Native American population. Two-spirited individuals within the Native American population are not seen in a negative context. If you look at this throughout history, they're actually seen as individuals with special gifts or maybe even a special holiness about themselves, and are allowed to participate in the community within the tribal community as they see fit that would best suit their own identification in the way that they want to express their identification. So some of the terms and characteristics, and these are things that we get bombarded with many times from different avenues within therapy. So we see this a lot. Sex, male, female. Sexual orientation is different. So that's lesbian, gay, bisexual, heterosexual, queer. How does the person identify? And the term queer once was kind of almost out of the vocabulary, but in the past 5 years, 8 years, good Lord, has been brought back in and used way more. Gender role, male, feminine, masculine, male, female, masculine, feminine, and then gender identity, transgender, transsexual, male, female, queer, and intersex. So if you look at some research that's been done on the Kinsey scale, which came out a long time ago, that actually kind of suggested that about 10% of the population was homosexual or lesbian. There's a lot of problems with this scale, a lot of problems with the Kinsey research. It was done predominantly on middle class, upper scale white men. It didn't include anyone else outside of that population. So there were some problems with that research, but that research held on to for so many years up until recent times when we really started to delve into this more, look at other ways of defining homosexuals and the coming out process in general. The CATS model, which I actually like this model, and I think it really walks through this quite well. So you have identity confusion. So there's this polarizing thing going on with the individuals, what they feel and what society says they should be. So what are the roles of society saying, and what is the way that I'm feeling? A lot of anxiety, a lot of denial, a lot of other ways to utilize skills, and then the comparison. So there might be something going on here. So the person starts to kind of define and wrap their brain around this. Yeah, okay, I think I might not fit that heterosexual lifestyle model. Identity tolerance. So actually becoming tolerant with yourself. This can make people really, really angry. And actually, within the community, people sometimes become heterophobic because of their anger against society in general and the way that they've been oppressed. And it's something that if you're working with someone that's part of this community and meets the criteria for this level, it's something that you really need to process with them to help them get to the self-realization of a healthier person inside their skin. And then the identity acceptance, where they really start to tolerate and identify themselves and identify the community. And there can continue to be rage, continue to be sadness, continue to look at themselves as, I can't believe I was locked in this belief system for such a long period of time. And then that transitions into more of a sense of pride and a sense of self-awareness and that self-actualization process that hopefully occurs. The identity synthesis is really where the individual becomes healthy, they become whole. Hopefully they've worked on the issues that have maybe brought them into your office, and that maybe you've walked through this process with the individual. This can take a long time too. People get really stuck up in the issues of identifying themselves because of the social stigma and the social issues that are out there confronting them on a daily basis, especially if they work in a very homophobic environment, which is still quite live and well in our communities. We're going in the right direction with this though. So if you look at the three-phase for recovery from shame, so breaking the silence, very important. So looking at, as it says, facilitate client discussion of hiding LGBT feelings. So looking at that, how did that make you feel? What has it cost to fit in? What have you given up? Really looking at that, and then looking at the feelings of blaming themselves, feeling wrong, feeling less than, and look at the client's ability to come out and be a strong individual. Establishing perpetrator responsibility allows clients to understand the struggle in the context of social discrimination and prejudice. So how do you manage that process in a healthy manner? Understanding and accept negative self-image as a socio-cultural, not personal. So it's a social construct. This is all labeling theory when you look at it. We label people. We label what we look at as a male role and a female role, and how people that fit into this category have had to label themselves, and how they've had to cope with that labeling. And then reclaiming their personal power. So really getting on the other side of that again, building supportive networks, looking at how they're going to continue to work with some of the issues that that has caused within their development, and how they can get beyond that and get to the other side of it, and do that in a very supportive environment. So some of the things that you have to look at with the LGBT community that are a little bit different are looking at, because many times the family has been alienated. So how does the family support that? How have they responded to that? Have people been disconnected from their life, from their family because of their coming out? And how are they going to deal with that? And what does that, how is that going to shape their life? And how is that going to shape their ongoing family development? Very important when you're working with people from the LGBT community to be aware of this. So some of the guidelines right here demonstrate support and understanding for the life and the partners and significant others. Be sensitive to the individual self-identification. Be sensitive to diversity and the variety of relationships in the LGBT community. Demonstrate support and understanding for the life partners and significant others. Be sensitive to the individual self-identification, and sensitive to the diversity and variety of relationships in the community. So, and that's, I guess that's redundant. So I think that just that awareness, and awareness when, if you go back to the different types of identities that are out there, and just a quick example, I have a friend of mine who is a male who wants sexual reassignment to a female, but considers themselves to be a lesbian. Okay, and people wrap their brain around that, and that can be hard, but that is the way that individual feels. Okay, and that they truly believe that that's what, that they were sexually assigned to male genitalia at birth, but they really believe themselves to be female, but they don't want, they want sexual reassignment to have sex with women as a lesbian, not as a male. Okay, just for example. So it can be really, things can come at you off their base, like they go, okay, fine, and then what's that going to look like? And then what are the barriers in society this person is going to have to be a healthy, functioning individual? Some of the myths. Lesbians and gay men do not have children. Well, a lot of lesbians and gay men do have children, and if you look at the research out there, it does not show that being a child of a lesbian or gay couple is a detriment. It has to do more with the quality of that relationship. So I think that's also something that's very important to note. I think that's maybe a little bit more on this slide than the other one. It's not going to make the person more likely to be, lesbian, gay, transgendered themselves. They may be an ally, but they're probably not going to, it's not going to have the impact on the child. And also the myth is people who are in contact with gay men or lesbians face increased risk of being sexually abused. There's no statistical data out there to take and promote that thought or that belief system. Another myth is that the gay men and lesbians have unstable relationships. I think gays and lesbians, and if you look at the research on this, are as stable as any other couples, especially if you look at what they have to fight in society many times through homophobia and inappropriate responses just being out together in the community. Hopefully that is lessened. However, you see with the rise in the gay and lesbian marriage rates out there, it has actually stirred up some of the counter beliefs on that, and I think sometimes made people a little bit more vulnerable depending on where you're at geographically as well. And in fact, a large number of gay men and lesbians can do and enjoy long, stable, and satisfying relationships. I think that's quite accurate. Myth, the only acceptable form of a child contains a mother and a father who are married to each other. This is the statistic I was looking at or was talking about earlier. And again, it goes back to being the quality of the relationship, because also remember that the child is being socialized within society as a whole, and they're not just being socialized within the family itself. Within a healthy family, you're going to look at all different types of relationships, hopefully, and help also the child identify where they may be within the context as well. Excuse me. LGBT communities are underserved and often invisible. It's important that treatment providers make commitment to serving the population and incorporate the commitment into its organization mission statement, philosophy, and service literature. Actually, the VA's come out with a huge treatment and identification of individuals within the veteran population that I identify with the LGBT community. I think if you look at just nationally, we're kind of behind on this, and it's something that there's been great strides and moves forward to work in this community and work with this community. So some of the to kind of recap, we've looked at some of the history behind some of the therapeutic interventions, some of the other concepts involved. Some of the cultural considerations, we've looked a little bit, and I've defined what my thoughts on codependency are. Some of the effects on substance use on the family system. We've looked at some of the special populations within our communities and within our society. And I hope that you've learned something from the lecture this afternoon and the webinar this afternoon. And I think now as we're going to open it for questions and see.
Thanks so much, Ed, and I'll just jump in here to remind people there has been some good discussion and some good comments throughout the presentation. If you haven't noticed, those are going on in the Q&A pod, which is just to the right of the presentation. And if you are in full screen, you'll want to exit out of the full screen mode so you can see that. So please submit any further questions at this point there, and we will address those. There have been a number of questions about how the handouts will be shared. So I'll just remind everyone that we send a follow-up email the day after the webinar that will include handouts of the presentation. It'll also include it'll include the link to the survey in case you missed that as we close out today. And it will also include a CEU request form. So look for that tomorrow, and hopefully that answers that question for everyone. Let's see. All right. While we're waiting for any additional questions to come in, I will just remind everyone too that we will be redirecting you directly to our GIPR survey right after we close out the webinar. So please take a few moments and go through those questions for us and let us know what you thought of today's presentation. And I'll just remind you too, the upcoming webinars that we have, they are available. There's a little links pod in the lower right hand corner of the webinar screen, which if you click on one of those, then hit the browse to button, then it will actually direct you right to the registration for those events. So please feel free to do that as well. And then Crystal just asked, I was able to get the handouts ESAS May 2015. Are these different from the handouts that everyone's requesting? No, that is the same. So some of you were probably able to download them from the files pod, but I know some people were having issues with that. So those same handouts will be sent in the email tomorrow. So either way you get them, it'll be the same. I don't see any other questions right now, but feel free to submit questions by email to me if anything else comes up that you're thinking about as you process what we've gone over today. And I hope everyone enjoyed today's presentation, and just want to thank Mr. Haycraft for coming and sharing with us. And Ed, did you have any final thoughts you wanted to share?
Being here today.
Great. Yes, thank you so much. And thank you to Ed, and we really appreciate you bringing your expertise. So with that, I will go ahead and close this out for today, and hope you all have a great day.